Dr. Lau is a board-certified neurologist with special qualifications in child neurology. She is currently assistant professor in child neurology at NYU School of Medicine and the director of the NYU Lysosomal Storage Disorders Program at NYU Langone Health and associate director of the Division of Neurogenetics. We welcome Dr. Lau today.
Thank you so much for having me here. I'm going to bring my slides up for you. Are you ready? Okay. Well, good morning, everyone. I'm so proud to be here and participating in the family conference. I'm excited to share with you what we've learned over the past several months. And so we'll talk today about the COVID-19 pandemic and the impact on the mucopolysaccharidosis. Here are my disclosures. And we'll talk a little bit about the impact of COVID-19 in general in the US and the multisystemic manifestations, an update on what we know about it. We'll look at the impact on special populations, including children, and talk a little bit about immunity and vaccine development. And then we'll tie that into how it's impacted our patients with MPS disease and talk about how can we manage our patients through this difficult time and a little bit about the impact on clinical research. So when we look at the impact in the US, this is data coming in from this past week. We have over 6 million cases that have been diagnosed to date. We have over 188,000 deaths in total. Just in the last 7 days, we've diagnosed another 288 cases of COVID-19. This is after we're testing over 91 million and having over 7 million positive tests come back. So we have an 8% overall positive rate in the US right now. And what we're seeing by state, initially, New York City was the epicenter and started to explode within March and April, reaching a peak in April. But now we're seeing a rapid decline in the New York City area. However, other cases are popping up, and now other states are now experiencing the same kind of surge that we saw in New York. And hopefully today I can share with you what we've learned in New York and how we've managed the pandemic as we start to enter the fall season. We're hoping that we don't have a resurgence, but we are prepared for that. In New York State alone, we have about 25,000 deaths to date. Just within the last few days, we have a new 880 new positive cases. So we're testing, we had 90,000 tests and only 800 positive cases. So it's important to note that we are continuing to test and to look for the sources of outbreaks throughout New York. And fortunately, we've seen a dramatic decrease in the hospitalizations, intubations, ICU admissions in the New York City area. And hopefully we can sustain that through our mitigation effects. So what do we know about COVID-19 as of today? Well, initially back in March, we learned, or we were gathering information from around the world, looking to our colleagues in Europe and in China to understand what this novel coronavirus was doing to our family and friends and our patients. And what we learned was that initially we thought it was a respiratory illness, predominantly manifesting with fever, dry cough, fatigue. It seemed to be a very severe form of a flu-like illness that would then evolve into some severe complications, including shortness of breath, requiring oxygenation, and for some patients, hospitalization. There were other manifestations, including myalgia, sore throat, headache, chills. And then we started to understand that there were actually some GI symptoms associated with this: nausea, vomiting, diarrhea, constipation. However, what we've learned, both from our colleagues in Europe and China and in personal experience with the pandemic in New York, we started to see other systemic complications of COVID-19 infection. We started to hear about the loss of smell or taste that could even predate or precede the fever or the cough. We saw complications including dermatologic issues, various rashes, COVID toes and fingers. We saw cardiac complications, myocarditis, and sudden death. A lot of patients who were admitted to the hospital and intubated ultimately required also dialysis, another area that was very severe with a shortage of machines. And then we also saw neurologic complications. We heard about ascending paralysis called Guillain-Barré syndrome, cases of encephalitis, neuropathy, and unfortunately stroke. And then in our children and our pediatric population, we started to see this new inflammatory syndrome that was similar to what we see in Kawasaki syndrome. We're naming it multisystemic inflammatory syndrome. And I'll talk a little bit more about that in the future slides. So over this time, we see that this is not just a respiratory illness. So what is the impact on the general population? So what we've learned so far is these non-respiratory symptoms, the cough, the loss of smell or the taste, lack of taste, or even the GI symptoms may appear before the fever and the cough and the shortness of breath. Most commonly reported symptoms in patients who are not hospitalized were fatigue, headache, and muscle aches. We did see sore throat and nasal congestion and runny nose as prominent symptoms. We also saw a co-infection. So some patients were initially tested for other viruses, but they were found to be co-infected with both the SARS COVID-19 as well as with another virus at the time. And some of the patients went on to have a concurrent community-acquired bacterial pneumonia, and that would necessitate antibiotic treatment. So as we know that most of our patients had a mild or moderate course, but there were certain patients that went on to have severe disease or severe complications of COVID-19. And so as we look over the cases, both in Europe and China and here in the US, we differentiate what group or what population would be at most risk of developing severe complications. And this is critical so that we could understand our own personal risk for our family, our friends, and our patients. And what we realized is that symptoms did differ with severity of disease. So as I stated before, certain symptoms like headache and myalgias were associated with patients that were not hospitalized. But we do see that fever, cough, and shortness of breath were more commonly reported among patients who were hospitalized than those with milder diseases. Now, there's atypical presentations, especially in our older adults and persons with medical comorbidities. They could have a delayed presentation of fever. And so in one study that showed over 1,000 patients that were hospitalized, fever was not present at admission in 44%, but it did eventually develop in almost 90% during the ensuing hospitalization. There are other features that upon further evaluation were associated with more severe complications, and that included an elevated white count, specifically lymphopenia or neutrophilia. Elevated liver function test also heralded potentially severe disease or complications. Elevated markers of inflammatory. So the high CRP and high ferritin levels were also associated with greater illness severity. So what are these risk factors that put someone at risk of a severe complication of COVID? Well, what we learned very quickly was age was a strong risk factor. And so in the early US epidemiologic data that was provided by the CDC, we saw the case fatality rate was highest, obviously in persons older than age 85, so ranging from 10 to 27%. That was followed by those who were in their 60s to 80s with a case fatality rate of 3 to 11%. And it dramatically decreases with each decade down, with under age 55 with a less than 1% case fatality rate, which is really important. However, when we looked at the hospitalizations, especially in the New York City area, we saw that there were just as many younger patients also hospitalized and intubated. So why were they at risk of severe disease? And what we quickly learned was that patients with comorbidities such as diabetes, chronic lung disease, cancer, chronic kidney disease, all were associated with an increased risk of severity for COVID complications. Other conditions, including cardiovascular impacts, so heart failure, coronary artery disease, congenital heart disease, and cardiomyopathies, all put people at a higher risk from severe complications. Hypertension, if it was uncontrolled, put patients at higher risk as well. When we looked at the Chinese data, it does confirm that most of the cases were mild to moderate symptoms in 81%. Severe symptoms characterized by difficulty breathing or low oxygen saturations or lung involvement on imaging occurred in about 14%. Now, critical condition, including respiratory failure, shock, or multi-organ system dysfunction, occurred in up to 5%. And in their reports, their case fatality rate was 2.3%. But if you looked at specifically those who were in the critical status, 50% actually did not survive. So that was very important information that informed us in the US. So among children, however, we did see that illness severity was much lower. 94% were either asymptomatic, mild, or moderate, and only 5% developed severe disease, and less than 1% had critical disease. So let's look at the US data. So when we're looking at the clinical progression from mild symptoms to severe critical symptoms, we saw that the median time to shortness of breath from onset of illness or symptoms ranged from 5 to 8 days. There's this critical window where patients would initially present and they were stable, but they could rapidly deteriorate within 1 week of onset of symptoms. And so the median time to this syndrome called ARDS, or acute respiratory distress syndrome, was a range from 8 to 12 days from onset of the first symptoms. So there could be a rapid decline in that second week of illness. And so among the US COVID-19 cases with a known discharge status, the portion of persons who were hospitalized was 19%. And those went on to be admitted to the ICU were 6%. So among all hospitalized patients, a range of 26 to 32%, or a third of patients, were admitted to the ICU. And once admitted to the ICU, the mortality rate ranged from 40 to 70%, depending on the study that you cite. But for those survivors, the median length of hospitalization was 10 to 13 days. So let's move over to asymptomatic or pre-symptomatic infection. What we realized was that our patients who were presenting in critical condition were still the minority. It was probably underestimated the prevalence of COVID-19 in our US population. And so studies are showing now that there are many more patients that never developed symptoms or had very mild symptoms. And in children, as many as 13% with a positive test for COVID-19 were asymptomatic. In another study looking at nursing facilities, residents who were infected with COVID after coming in contact with a positive healthcare worker, 50% were either asymptomatic or pre-symptomatic at the time of the contact tracing and evaluation. So this is definitely a source of our spread of our infection, our patients that are asymptomatic or pre-symptomatic. And so some of our patients even had no symptoms, yet they had findings on their chest imaging. So we see that, the increasing numbers of the COVID transmission can occur during this incubation period when you're not symptomatic. And that's very important to understand how this spreads so rapidly throughout the community. So let's move to children. So children presented with similar symptoms as the adults: fever, fatigue, headache, aches and pains, cough, congestion, sore throat. And some of them did have some GI upset, abdominal pain, diarrhea, or vomiting. However, these symptoms are very nonspecific. They could be attributed to flu initially, or strep, or other types of viral syndromes that we see commonly in children of this age. Fever is not uncommon. The most common symptoms in children that were positive for COVID were cough and fever. But as I said before, there's probably many more patients or many more children that were asymptomatic, but they were carriers of the virus and able to spread it. So the lack of specificity of these signs and symptoms and the significant proportion of asymptomatic individuals makes it really difficult to screen children based on symptoms alone. So we have to have a high suspicion in the community. So while the children comprise 22% of the US population, data shows, as of recently as in August, that 7% of all cases were attributed to children. And so other studies have shown that children likely have the same or higher viral loads in their nasopharynx compared with adults and can spread it just as effectively in households and camp settings. But why are we seeing such low numbers? Well, what we did in March, and after we had the explosion of cases, we shut down schools. And so we had these community mitigation measures that effectively prevented this transmission and spread. And so that's why we might have a low incidence in children as compared to adults. And so we really need to understand our children, you know, there's some discussion of whether or not children are effective spreaders. We don't know that. We will know that as we start to return to school and have in-person school and other activities. So on the one hand, I think by closing schools very early, we dramatically reduced the spread. We flattened the curve, so to speak, in New York City pretty effectively. And now we're going to watch and see as we reopen and start to have more in-person activities, what will happen to that. Okay. So let's talk about severity. I want to stress that the overwhelming majority of children with COVID-19 have a mild course, okay? But yes, there are certain children that will go on to have a severe illness or complications related to COVID. And so when we look at that data, we want to, again, just like we did with the adults, what puts a child at higher risk of these complications of COVID-19? So again, children are less likely to be admitted to the hospital when compared to adults. However, once they're admitted, we do see a similar rate of requirement of ICU admission. So how do we stratify these children? And that's what I've been tackling with my patients in my practice, understanding the risk of severe COVID complications in my patients with rare disease, specifically lysosomal storage disorders. And so when we're looking at that and we're looking at the data, we're starting to realize that there are underlying medical conditions and age also play a role in children in children who will go on to develop severe illness. So we found that infants less than 1 year might be at higher risk, and other comorbidities similar to the adults. So there's the guidance from the American Academy of Pediatrics that does state that children with medical complexities such as genetic, neurologic, metabolic conditions, or congenital heart disease might be at increased risk. Those with obesity, diabetes, asthma, and chronic lung disease, and immunosuppression. So again, we're seeing that underlying disease would put you at a higher risk of complications. And these children do go on to develop severe complications, including respiratory issues, cardiac involvement, shock, sepsis, coagulopathy, and this new disorder called multi-systemic inflammatory syndrome in children. So what is that? Well, you know, in the medical community, we do understand that there are post-infectious syndromes that occur. We've seen it before in other viral illnesses. But because we saw so many patients being affected with COVID-19, we started to see these rare complications of the disorder. As a neurologist, we've seen Guillain-Barré after a viral illness. We've seen encephalitis after or part of a viral illness. And now we have seen inflammatory syndromes after other types of illnesses. So here, what we started to see in the US as well as around the world is this inflammatory syndrome that presents many weeks after actually infection with COVID. And sometimes the child may not even know that they were infected. So they were asymptomatic of the initial infection, but then they went on to have a post-infectious inflammatory reaction. And that presents with fever, abdominal pain, vomiting, diarrhea, skin rashes, and lesions, mucocutaneous lesions. And that could go on to some severe complications, including shock. They have elevated markers of inflammation, and they can go on to have cardiac involvement and kidney injury. Again, this is a very rare complication, but it is on every pediatrician's radar when a child presents with these constellation of symptoms, and they need immediate hospitalization and care. Okay. So this MISC is on the minds of all parents, especially those of our parents of rare disease with their children with rare diseases. So let's focus in on MPS and the impact of COVID-19 on our patients. So in March, when I could see that this was coming to the New York City area, we quickly went to cancel in-person visits, patient visits. And knowing and understanding that this disease was novel and we didn't know what to expect, we erred on the side of caution and started to call and do an outreach to all of my patients. We gave guidance. We said, we don't know your individual risk. We don't know what COVID-19 will do for various patients with rare diseases, but let's err on the side of caution and immediately start to self-isolate, so sheltering in place. In that outreach, we actually gathered some information, some data, and we're continuing to gather this data. We called 180 patients of mine that have a variety of lysosomal storage disorders. 145 were reached. And over the ensuing months, we realized that 28 ultimately ended up with either suspected or confirmed COVID. And the breakdown includes 25 Gaucher, 2 Fabry, 1 MPS to date, 0 Pompe patients. Most of my patients described a mild to moderate course with fever, lethargy, muscle aches lasting anywhere from 5 days to 3 weeks. Describing a severe fatigue, inability to get out of bed. There were 2 ER visits, 1 hospitalization, and unfortunately 1 death. And in that patient, she had a Gaucher disease and significant comorbidities, including not related to her lysosomal storage disorder, but COPD, which is a respiratory issue, hypertension, and she was morbidly obese. So we actually had 3 asymptomatic. They were tested because family members were positive. So the take home here is that most of my MPS patients were probably not exposed because they immediately took the advice to shelter in place. Schools closed down immediately, and they were self-isolating. During this time, we did have 2 exposures, and it ended up not being manifesting. The one patient that ended up with a positive test, she was actually completely asymptomatic, and I only found that out 2 weeks ago, that she was in a chronic care facility, and they were cohorting, and she made it through a few months, but ultimately was exposed and became positive. But she ended up having no symptoms. She had underlying Sanfilippo. So what can we learn from this? Well, I think, it's hard to know the actual effects of COVID-19 in general on a variety of rare diseases, but we can make hypotheses. So when we think about our patients, we have to really individualize the risk. And it's based on the baseline disease burden. How significant is their underlying comorbid medical condition? So respiratory dysfunction, obviously with impairment in their pulmonary function, would leave them at risk. Just as any other year, when we talk about flu risk, we always caution our patients about that they're at higher risk of flu complications. So why would it be any different here? And so respiratory dysfunction at baseline would put you at higher risk of complications. As we know, a lot of our patients have difficult airways. And so if and when they needed intubation, it would need to be done in a very controlled and expert hands. And the ER and the ICU needed to be aware. And that was part of my outreach to not only my patients, but to my colleagues in the hospital who were seeing droves of patients into the ER. And so there was an alert in everyone's chart to contact me if one of my patients showed up in the ER. Because of they could rapidly decline and require intubation. So again, having a COVID-19 infection could exacerbate your underlying pulmonary dysfunction. Sleep apnea as well as CPAP use could actually be a potential spreading event because of it's not a closed ventilation capacity. Cardiac dysfunction, or patients have valvular diseases, valvular involvement or cardiomyopathy, and so therefore that would put them at increased risk. Kidney failure was seen in our patients with severe disease. Fortunately, in MPS, generally they have normal kidney function, but again, this is another system that could be affected in our patients, and the liver and spleen as well. And as I mentioned before, we saw neurologic complications. Our neuronopathic patients, or patients with neuronopathic MPS, you could see an exacerbation of their underlying seizure disorder just based on having a fever alone. However, we did see some evidence of encephalopathy and encephalitis and increased stroke as well. We also saw peripheral nerve damage and autonomic dysfunction. So that could exacerbate any underlying neurologic complication for our patients. And of course, we need to be aware of our C-spine when we are intubating our patients. So to date, there's no cure or no specific way to treat COVID-19. There are many studies going on right now, and I did a quick search last week just to get an update on things. So if you look at the CDC website, we'll see that there's lots of different medications that are being tried to manage, to help manage and prevent the progression of COVID-19. So there's insufficient data for the following therapies, but there are clinical trials looking at the efficacy of the chloroquine or the hydroxychloroquine, HIV protease inhibitor, so other antiviral medications, ivermectin, looking at inflammatory modulators, so interleukin-6 inhibitors, interleukin-1 inhibitors, interferons, and looking at adjunct nutritional therapies, vitamin C, vitamin D, and zinc. I do want to warn you that zinc overdose can lead to spinal cord degeneration, so you have to be very careful if you are self-treating or self-medicating to not overdose. All of these medications have side effects, and we have to look at this and weigh the side effect potential versus the unknown benefit. And so these are done, and we are doing it here at NYU, various protocols to understand whether or not we can prevent the progression of disease. Right now, under emergency use authorization, convalescent plasma and remdesivir are being used. So they're not FDA approved per se, but they are authorized for use, as well as corticosteroids was shown to be beneficial in severe COVID-19. And we can also talk about how those work. But the idea for the convalescent plasma is that we're getting plasma from patients that were exposed to COVID, getting their antibodies and giving it back to them to see if they can help fight off the virus. But the second phase of that virus, there seems to be inflammatory dysregulation, and there's overwhelming cytokine release. So there's a role for immunosuppressive therapy in severe COVID-19 when it progresses on to that ARDS. And so we are seeing some benefit from steroids, okay? So a lot of questions come from my patients about, well, what if I was exposed and I had antibodies? Am I now immune? Well, we are seeing more and more patients going for antibody testing. And so right now, all we can say is that if you have a positive antibody test, that means that you were probably infected at some point in the past. It doesn't mean that you are currently infected, and they're not used to diagnose a current infection. But it means that you were exposed to the virus and your body has generated an immune response. And these antibodies generally develop 1 to 3 weeks after infection. And so right now, there's not enough information to say whether someone who has these antibodies are definitely immune and protect them from reinfection. We're watching patients very closely to see if this immune response is wanes or decreases over time, and whether or not it is protective. So therefore, you should continue to take strategies to prevent and protect yourself from exposure, including continuing to use masks and wearing PPE as appropriate. We should not use these antibody results to determine whether someone should return to work or school. So what are we doing to try and prevent COVID-19? And this is really important because it typically takes years to develop an effective vaccine. And right now, there are many companies around the world trying to develop and test out vaccines. There are 9 leading US and European vaccine developers right now that all pledged as of September 1st to uphold safety and efficacy standards. We need a vaccine fast, but we need it to be safe and efficacious. And so right now, AstraZeneca, Pfizer, GlaxoSmithKline, Johnson & Johnson, Merck, and Moderna, Sanofi, and Biogen are all developing vaccines. There are currently phase 3 trials even underway. So that means that, they've passed through the initial phase 1 and phase 2, and now they're recruiting over 30,000 patients volunteers to test out this vaccine. So in AstraZeneca, Pfizer, and Moderna. However, and again, this is just updated for this week, there was a halt in one of the studies. So for the phase 3 vaccine studies that I'm highlighting, AstraZeneca study and the Moderna study. So AstraZeneca is based on using a weakened viral vector to a weakened adenovirus vaccine. And it's changed so it doesn't replicate inside your body, but does stimulate a response, immune response. However, it was halted due to an unexpected adverse reaction. And all the details are not provided yet, but a patient developed a transverse myelitis or an inflammatory syndrome within their spinal cord. They do not know if it's related specifically to the virus or not. We do see this after other viral illnesses. So right now, the trial's halted and there's a further review going on. And this is important that we do this. This happens in research all the time. And so it's important that they stop, they halt, and they look at what's going on. In the Moderna study, it's a different approach. It's using mRNA. And if you have questions, you can ask me later about what the difference is. But in this case, this is not a viral vector delivering it. It's naked mRNA that's being provided to help stimulate the immune system. Okay? So until a vaccine is proven and safe and effective, we still need to have mitigation strategies. So as the disease starts to spread again within your community, especially as the flu season approaches, the following guidelines are recommended. Get your flu shot. As long as there's no contraindication for a flu shot, such as allergy, your patients with rare diseases, including our MPS patients and family members, need to get their flu shot. We need to prevent that co-infection. The last thing we need is to have both your body trying to fight off the flu and COVID-19. Continue limiting contact with others outside your immediate family. And do not congregate in large groups. When you're outside, we realize what we've learned specifically in New York, wearing a mask helps. It helps you and it helps the other person. Maintaining social distancing 6 feet apart is also helpful when you can't wear a mask. Do not touch your face, use hand sanitizer, and avoid crowded places. So how do we manage MPS during this pandemic? Well, one important aspect is that, initially certain patients were putting their enzyme therapies on hold because they were scared. They were scared of exposure. And that was understandable, especially when we didn't completely understand how it was transmitted, how easily, and what are the mitigation strategies that are effective. But as we realized that this was not going away anytime soon, we really needed to figure out how to get our patients with MPS to their therapies. And so in our hospital or in our clinic, we did outreach to all the home infusion agencies and the infusion centers. And I'm sure this is being done now across the country. So there's various strategies to prevent or to reduce the risk of exposure and spread within a home infusion center, within the infusion centers, and even by having nurses that come into the home. And there's some guidance here. We need to continue our subspecialty follow-up. A lot of our medical visits were put on hold. We converted to telemedicine pretty effectively, but still our patients need to have their cardiology assessments, their echoes, their EKGs, their pulmonary function tests. And it's important that we do not delay necessary surgeries. And so again, I think the hospital and the medical community has learned how to deal with this. Initially, we were overwhelmed just with the resources. And that's why we had to close down the hospital and switch over to COVID care. But now we understand how to mitigate the spread, and we're having patients come back for in-person visits and evaluations. Rehab services are critical to our patients with the requirement for PT and OT and speech. We started home-based therapies and telemed-based therapies, and in certain cases now are resuming in-person care. Again, we need to understand how we can continue receiving our medical care for our patients with MPS while also reducing their risk. it's very difficult, but we need to figure out how to manage and navigate. This is not going away anytime soon. So a comment about education. So the American Academy of Pediatrics is actually recommending in general that children return to in-person instruction with precautions. And there are lots of caveats about different scenarios, but they realize that our children, in remote learning, there are definite downsides to remote learning, especially children with cognitive issues. So our neuronopathic MPS, or patients with Sanfilippo and severe forms of MPS 1 and 2, they're not going to be able to effectively learn through online means necessarily. They need more hands-on learning, one-to-one interaction. There's lack of socialization for our children with autism spectrum disorder. And behavioral issues could be exacerbated when they're no longer in a routine or schedule. It's interesting, some of my patients thrived at home-based instruction, even though they had cognitive delays, and others, there were behavioral issues in some of my Sanfilippo patients. And it was very trying and very difficult for the parents who were trying to work and manage their children at home. So in-person learning, there are a lot of school districts that are suggesting some form of hybrid learning where they're going back to school, but then that's creating a lot of anxiety in our patients. So it's really an individualized decision, and the impact, the in-person learning is difficult because our patients with Sanfilippo and other severe forms, they can't wear the mask all day. They're not going to be washing their hands. They're going to be touching their face. So there are different strategies within that classroom that have to be taken to reduce their risk. But again, speak to your physician about you or your child and your individualized risk of severe complications and how to reduce that risk, okay? And the final slide here is just a comment, and I'm sure Dr. Munzer will go into more about research. So the pandemic halted a lot of things, elective surgeries, routine medical care, and research was impacted. And it was very critical for my research group and to figure out how to continue to conduct research during this time. We cannot stop research. We have to find ways to go on with gene therapy and other research studies. The patients are still progressing regardless of the COVID-19. So there are strategies that the sponsors, the pharmaceutical companies, the academic institutions are taking to reduce risk. We're doing more telemed visits, remote consenting. We're using what we learned in our telemedicine efforts to research. And it's really important that we figure out how to continue this, because this is not going away in the next 6 months or a year. And so there are strategies that are working. And I'm happy to say that I was able to conduct safely my interventional trials for MPS during this, during the pandemic, safely and without, and by reducing risk to staff and to the patients. So overall, COVID-19, we've learned a lot since it's landed on our shores in the US. It's a multisystemic disease that ranges from asymptomatic to severe. The increased risk of severe complications we observe in the elderly, but also in children with medical comorbidities, such as cardiovascular and pulmonary disease, diabetes, and obesity. Our MPS patients are likely at a higher risk of severe complications based on their baseline disease burden. And it might vary within the subtypes of MPS. And so it really needs to be looked at individually with your caregiver and your physician. There are no proven therapies to prevent or treat COVID-19 right now. We are attempting, and we're looking at different interventions. And vaccine development is underway, but it takes time. And until it's available, our vulnerable patients and family members need to continue mitigation strategies to reduce this risk of exposure. Your individual risk should be discussed and talk about how you can go forward with your medical care, with education and work. And that should be continued during the pandemic. And hopefully all of us are able to continue our research efforts to help our patients. Thank you. And just one last slide. This lecture is in memory of my patient, Alexandra Hernandez, who had MPS 6. I met her 10 years ago when I first started in this field. She had a very difficult course this past year, and she was actually hospitalized during the pandemic, but she She never got COVID-19. I learned so much from Alexandra. She has been a source of inspiration and part of the reason why I continue on in this field. And so, you know, despite this pandemic, we were able to continue our care for her. She needed to come to the hospital. She needed to be effectively cared for in the ICU, and we were able to do that. And so I just want to just say that she will inspire me forward, going forward. And she's in my thoughts every day, as well as her mother and her father, Christine and Albert. Thank you.